We're going to move again to a new field, not only from academia to another field, which is industry. And I'm happy to present Lynn DURHAM, who is not a psychiatrist, not a biologist, but she's an entrepreneur. She's the CEO and founder of a company which is called Stalicla. And Lynn has a lifelong commitment to the world of autism, and she's created one of the first platforms to really promote innovation in precision medicine for neurodevelopmental disorder. And I think she's going to show you outstanding results for this field. So thank you very much, Lynn.
So thank you for the title on a mechanism-based strategy in autism, because I think it translates well the approach that we've taken to neurodevelopmental disorder and therapeutic translation in neurodevelopmental disorders. So we operate as a company, so we're 35 people dispatched between Barcelona, Geneva, and running clinical trials in the US, Australia, and Europe. Our company Stalicla is divided in 2 units. So we have our drug development unit in Geneva, where we have a team of 20 operators with background in CNS drug development, and a team of 25 systems pharmacologists, computational biologists, human geneticists, and chemoinformaticians, as well as data scientists, working from our offices in Barcelona for the last 7 years, where they've been developing our platform. So our platform is the first platform specifically addressing precision medicine, or specifically developing a translational approach for precision medicine in neurodevelopmental disorders. And it has driven our company towards the initiation of 2 programs that are now phase 2 ready in precision autism. And we've also more recently introduced a neuropsychiatry vertical with our mGluR5 NAM vertical. The mGluR5 more recent involvement stemmed from actually our platform, because our platform is end-to-end, going from patient stratification to drug, but can also operate in the reverse direction, starting with drugs, generating basically gene expression signatures from drugs and treatment of neuronal and non-neuronal cell lines with drugs, and reverse engineering the phenotypical profile of patients most likely to respond to these drugs. And we obtained through research collaborations with U.S. academia, notably Cincinnati Children's Hospital and Rush University, some encouraging results on capacity of our platform to blindly recall responders to previously mixed trials in the field. And this convinced Novartis that our company had potential for further development of their mGluR5 NAM mavoglurant asset that had been trialed in multiple neuropsychiatry indications, and notably in neurodevelopmental disorders. So I mentioned our team. So this is more. This comes from our corporate deck. So I apologize to the audience for sort of a corporate formatting of the deck here. But our team, our discovery and data science team, is led by Emre Gune, who's our CTO. He has a background in systems medicine, trained as a computer engineer, and then did his postdoc at UPF, and then at Northeastern in systems medicine, Dana-Farber, and Maastricht University. So really a systems medicine background. And then Laura Perez-Cano, who's a computational biologist by training, and did her postdoc at the Geschwin lab at UCLA, which is a leading lab in neurodevelopmental disorder and autism genetics. And basically with them, we decided to build the puzzle that we were not seeing in neurodevelopmental disorders, integrating capacity from other fields of medicine with neurodevelopmental disorder genetics to start finding ways through statistical modeling, integration of AI models as well, for integration of health records and looking at associations at higher rates than would be expected by chance of phenotypical features with DSM-5 diagnosis of autism. Then the rest of the team, the management team, are drug developers. So Thomas Blattler from Roche and various different biotechs recently joined our team, and he's a late-stage experienced drug developer in the CNS space. And Vikas Agarwal, who's based in Boston, was also joined the team recently as we scaled, and he's a flagship operator. So the goal right now is to really scale the company as we move forward in our precision trials. You will also notice the scientific advisory board, who are key players in the neurodevelopmental disorder space, with Liz Berry-Kravis, who has been a pioneer in biologically stratifying monogenetic patients, notably with Fragile X in the neurodevelopmental disorder field. Craig Erickson, who operates the Autism Discovery Unit at Cincinnati Children's Hospital. Dan Gushfin, of course, from the UCLA Gushfin Lab, who's a distinguished professor of human genetics at UCLA. Dan Curie, this is our access to clinical records through the Autism Treatment Network, and more recently, John Crystal, who's a chair of psychiatry at Yale, with a strong focus on addiction and mGlu5 NAM. So I mentioned both of our verticals. So our first vertical operates from the DPI side. So DPI stands for Database Endophenotyping Patient Identification, and it is the Precision Neurodevelopmental Disorder platform that we've been developing over the last 7 years. The first indication for the treatments discovered within the Discovery and Data Science unit are precision autism spectrum disorders. So I think that it's a very well-known fact that there are no FDA or EMA approved treatments targeting the core symptoms of autism. That the number of patients diagnosed with ASD is around 10 to 11 million in Europe and the US, and 1 in 36 8-year-old school children in the US are diagnosed with autism spectrum disorder, according to 2020 figures from the CDC, and 1 in 6 children are diagnosed with neurodevelopmental disorders, according to 2023 figures from the CDC. I will, alongside my presentation, further comment on these figures because, and this was mentioned in previous presentations, there's poor construct validity to DSM-5 diagnoses, and that's notably the case in autism. And we see this, and we can say this through different elements. The first one being that genes and molecular pathways that are or genes that have been associated with a heightened risk of autism very strongly overlap with genes of risk for ADHD or even schizophrenia and other neuropsychiatric disorders. So the clinical and from the other side, the clinical manifestations of autism are poorly predictive of underlying biology. So we have to operate within a regulatory framework, notably when we are operating as drug developers. And the challenge is to report to a division when you're doing drug development that is focused solely on DSM-5 classification, and coming to them saying, we will operate within DSM-5 classification, but allow us to further restrict our indication. So rather than contesting the DSM-5 indication when you're doing drug development, you can say, allow us to make life harder for ourselves and have additional inclusion criteria beyond the classical DSM-5 diagnosis. So that's been our strategic approach to drug development in a field where DSM-5 entities don't really overlap with the known genetics of neurodevelopmental disorders. And of course, the mGluR5 NAM, so our interest in mGluR5 as a company, our interest in mavoglurant as a company stemmed from the Fragile X space and its application Fragile X, where the clinical results on mavoglurant were mixed in Fragile X patients. It's important to mention that Fragile X also, even in monogenetic disorders with psychiatric manifestations, you also have intrinsic heterogeneity. So this can be illustrated in Fragile X through variations in methylation status, but even variations in methylation status are not fully predictive of response to drugs. So basically, our idea at Stalicla is to integrate various levels of data beyond DSM-5 diagnosis and look for clusters through computational methods, so associations at higher rates than would be expected by chance of association of psychiatric disorders with biomarkers, but also with family disease history of other diseases, leveraging on the concept that genes and molecular pathways that are involved in the development of autism are also involved in other organs and diseases. And that nicely bridges with the previous talks on immunopsychiatry. So the platform in itself, so DPI platform and first indication in autism. So the core idea behind our platform is to address one by one the key roadblocks that we believe have impaired the development of effective treatment options for subcategories of patients with autism and neuropsychiatric disorders. So I think the first one, which is sort of the obvious go-to suspect, is the patient heterogeneity. And we've addressed this amply throughout the morning. And this is really the core or the starting point for DPI. It was saying, how can we address the heterogeneity within patients with autism when more than 1,000 genes and pathways, or 1,000 genes or risk genes have been associated with an increased risk of autism, and that these 1,000+ genes only account for 20% of the population with a DSM-5 diagnosis of autism, and 80% of the population remains idiopathic. So I always like to say that idiopathic is an elegant way to say we have no clue. And that I like to say that idiopathic patients are syndromic to be, not obligatorily monogenetic patients, but we in autism, I think it's a good example for psychiatry in general. We're mostly talking about additive risk variants, and so we have to sort of layer the different types of data that we can collect to be able to make sense and start identifying clusters. Then the fact of including patients solely based on a DSM-5 diagnosis, which actually we believe is a difficult starting point for the identification of consistent soluble biomarkers, or at least biomarkers that have specificity and sensitivity, because I think we can find very large clusters of biomarkers in psychiatry in general, let's say brain diseases that have commonality between autism and ADHD and immune-driven depression. But that if we solely start, or we choose a starting point as the DSM-5 entity, we're actually, in not crossing this data with other layers of data, we're actually making our life more difficult and less sensitive and specific from a biomarker perspective. So what we've done is that we've integrated the DSM diagnosis of autism in these patients with within electronic health records with other layers of data. So a family disease history of other diseases, and I've seen very nice presentations before, taking this similar approach, but also morphotypes, because genes and molecular pathways that are involved in the functioning and development of the CNS are also involved in other organs and diseases. So our idea was to say, but wait, historically in genetics, how did we identify syndromes? Well, through phenotypical non-behavioral manifestations. And it's not because these syndromes were monogenetic that you could not take a similar approach in polygenetic conditions and start identifying clusters of morphotype or increased susceptibility to disease. So measurements are often subjective, variable, and unable to separate noise from signal. So here I'm taking the sort of a translational cross path, saying, okay, how do you develop drugs? And one of the key points to developing drugs is measuring their effect and the choice of endpoints. And so on top of classical in our autism field, on top of classical autism behavioral checklists, social responsiveness scale, we've included performance-based measures that are not based on subjective clinical measures, so computerized based measures. The NIH toolbox is becoming very big right now in rare disease and neurodevelopmental disorders because it's performance-based. Very nice example is Tetra Therapeutics, recently acquired by Shionogi, which is a PD4D treatment in Fragile X, where the FDA has actually accepted to include the NIH toolbox as a primary endpoint. We like this because the NIH toolbox, or these performance-based measures, actually measure changes in pivotal skills that are easier, in which it is easier to see early changes in response to pharmacological intervention. I'm thinking processing speed, reaction time, and these elements act as pivotal building blocks to see longer term changes in social communication. We also like to integrate EEG, and we've done this systematically in our interventional trials, measuring EEG at baseline and after intervention and correlating these different measurements. And of course, just to summarize the overall approach, we're going beyond target-based drug discovery approaches, which is well suited for one target gene, one disease models, but that is definitely not suited. And here I'm going to go beyond autism, saying definitely not well suited for psychiatry, because most of neuropsychiatric disorders are polygenic conditions. And so characterizing drug effect at the pathway level, and here I'm putting a little side note talking about gene expression profiling, because advances in systemizing gene expression profiles, I think, are a very strong path forward in neuropsychiatry and in our capacity to be able to stratify patients at the pathway level. So of course, there's an enormous space for metabolomic and blood-based biomarkers, but how do you get to these blood-based biomarkers? Well, taking a pathway clustering approach to be able to find patients who have physiological measures that strongly correlate with genetics and biology, and then validating these patients prospectively in observational biosampling studies allows us to select these populations that are an adequate starting point for drug development. So this is a high-level representation of DPI. We've recently published on the first results of the platform. So DPI integrates multiple levels of data. So it took us several years to establish partnerships that allowed us to build a training data set. So we have obviously access to the Simons Foundation data set, but also AGRI, Missing, which are large autism data set. Then some multi-omics profiling from individual clinical centers. And we're taking a systems approach to clustering while integrating this data. And this is for hypothesis generation. So we generate hypothesis on the basis of saying, okay, we predict associations at higher rates than would be expected by chance of patients having a DSM-5 diagnosis of autism and macrocephaly. I mean, this is an easy one. 20% of patients with autism have macrocephaly, which correlates very well with cellular proliferation genes and immune regulation genes. So you see this is an example of what can be done with features that are already known in neuropsychiatry and in autism in particular, because when you're doing that, just this simple association, you're probing for known genes and even unknown genes that are associated with cellular proliferation and immune function, and that have a physiological implication or circuit level implication in the pathophysiology of autism in terms of regulation of synaptic pruning, for example. So just this association there, and it's an association that is proven at higher rates than would be expected by chance. And then layering additional associations based on training electronic health records. And then once you find these associations, what do you do? So first of all, you verify them in prospective observational studies. This is a very intensive clinical effort, but also financial effort. The company has spent over 30 million in the last 7 years in observational biosampling studies. And then once you have these clusters, you want to verify them. So as I said, we verify in prospective observational studies these associations of non-behavioral clinical features in association with a DSM-5 diagnosis of autism, and we collect biomarkers, because I think that's the point where you want to collect biomarkers when you've previously enriched on with a systems approach your population, and that's when you start seeing biomarkers. And then the next step, and I will go into more details about how we do this, and then the next step is saying, okay, once I start identifying biomarkers, what is the most translational biomarker for drug discovery? And there's been a big movement in psychiatry on, as I previously mentioned, gene expression. I think gene expression has its pros and cons. It can be noisy, and you need to establish proper SOPs in the way that you collect RNA. I like that our team has established with the clinical sites we collaborate with the collection of RNA at 3 different points in time. So we sort of correct for short-term environmental factors. So that gives more prediction. And then we establish a heat map. So what do we mean by a heat map? So basically we enrich we filter for genes that have been previously associated with autism and neuropsychiatric disorders, and we look at how these genes are upregulated or downregulated versus control populations. And that's what we call sort of our heat map signature. And then we treat, so we have a high throughput sequencing facility where we expose a different type of small molecules to neuronal and non-neuronal cell lines, and we generate signatures for upregulation and downregulation of genes, and then we compare these heat maps and we pre-select candidates. Then once we've pre-selected these candidates, we take patient-derived cell lines from enriched populations with a DSM-5 diagnosis of autism from our prospective studies versus non-enriched versus controls. And we look at the specificity of the effect of the drug. So that's our discovery process. So we've ran numerous, so I always say we have second level data, which is from large cohorts, of course, UK Biobank, more specific autism cohorts, and first level data. First level data we consider is the most precious. We've ran in the last 5 years 2 biosampling observational studies, one at Cincinnati Children's Hospital, the other one at the Greenwood Genetics Center. The first one was 313 patients. The second one was 222 patients with autism, and we collect 100 individual clinical data points, essentially non-behavioral, plus whole genome, RNA, PBMC, and plasma. And we validated that our first patient population, so-called phenotype 1, in a metabolic assay called the Biolog assay that is basically a colorimetric assay that measures production of NADH when cell lines are exposed to various metabolic effectors, growth factors, and cytokines. And we identified that the phenotype 1 patient derived cell lines produce a metabolic boost when exposed. So that brings us back to metabolism, a metabolic boost when exposed to cyclic AMP. And we have the same results with the drug, so STP1, and I will comment on this afterwards, versus non-enriched populations with a DSM-5 diagnosis of autism and controls who do not produce this boost. So the N here is 25 patients with phenotype 1, 20 patients with non-phenotype 1, and 20 controls. And the drug, so our candidate drug here that we established through a gene expression profiling screening is a combination of PD4/3 inhibitors. So you see that there's an immune targeting here with NKCC1 antagonism that actually balances the activation of NKCC1 for increase of cyclic AMP, and that corrects this molecular signature. So this work was recently published, actually last week, because as a biotech we also have to generate IP. So this is very frustrating, but we published this work recently, and it's work that dates back a couple of years. And so we then built a non-clinical package and brought this forward in interventional studies in the US with the first POC phase 1b studies, which was a randomized double-blind placebo-controlled parallel group 2 dose ascending study, which was a first in human. It's a POC study, so it was 2 weeks BID dosing with a follow-up period per subject, 2 weeks post-treatment plus 28 days. The first cohort was a low dose 5 milligrams combo IBD less than permitine. Second, 2 placebo, 6 active. Second cohort, high dose 10 milligrams, 1 milligram combo, 1 placebo, 3 active. Inclusion criteria: phenotype 1 patient, so an enlarged head circumference at any point in time in the first 24 months of life. So we're probing for the cellular proliferation and immune function genes, and specifically a circumference greater than or equal to the 75th percentile, and ASD symptom flares during episodes of immune activation, such as infection. So here we're talking about sickness behavior or acute neuropsychiatric worsening, which is also a phenotypical prob for involvement of specific immune regulating genes. And what we saw, I mean, these were early results, was interesting readouts on the autism behavioral checklist with changes from baseline in active versus placebo, social responsiveness to social awareness. These are classical autism severity measures, and more notably on the NIH toolbox, because that's where you observe more rapid quantifiable changes. But most interestingly, we also collected so QEEG on these patients, and we found that these patients presented with statistically significant, highly abnormal resting state gamma wave paradigms. So usually in neurodegeneration, there's a lot of question around gamma wave measurements. It is a well-established paradigm in neurodevelopmental disorders, thanks to all the work that was done in the Fragile X space. And we really see that with the drug, we see a dose dependent correction of this highly abnormal resting state gamma wave that we also see, and this is a very specific neurodevelopmental disorder paradigm, neuronal synchronization improvement in the auditory chirp task. So here we're measuring basically Hertz frequency when patients are administered a noise, basically, and we're looking at how they're locking onto this signal, which is also from a translational clinical perspective an important translational measure, because we're measuring, it's a direct measure of awareness and awareness to their environment. So that's a baseline that can allow patients to learn. And we can see that with a high dose, we have highly statistically significant near correction of this chirp paradigm. And the Cincinnati autism target engagement unit says that these were the strongest results that they've ever seen in the autism space, and that this was only observed in full knockout Fragile X mice. It makes people laugh when I say this, because we're comparing, clinical, but it just shows that when you enrich your population, you start seeing things that are very interesting and that can translate clinically. And this was a POC study. So metabolic, so enrichment of the population, metabolic validation of early biomarkers, validation of a signature at baseline on EEG, contextualizing that within the context of neurodevelopmental disorders, and PK/PD modeling that correlates with the EEG data. So early trends of efficacy on classical autism efficacy measures. So now we're preparing our 2 phase 2s. So we did sort of the same thing with the second phenotype of patients, and we're recruiting among 30 sites in the US, Spain, Australia, 1,200 patients. The idea is to pre-screen patients with ASD phenotype 1 and phenotype 2 that will participate in the STP1 and STP2 trials. So we will activate these sites as treatment sites. We are also looking to collect additional blood samples from phenotype 1, phenotype 2 patients to advance the validation of a potential blood-based diagnostic tool. And of course, support. I mean, we have shareholders, and so we need to advance and expand our collaborations. And so we're also looking to expand our partnerships with pharmaceuticals by enrolling patients from past clinical trials to identify responder subgroups and open opportunities for in-licensing and positioning of new compounds. And then we're enriching Stellicla's proprietary database for the collection of this rich data set. So I will finish with the trial design with STP1 clinical development program for phase 2, which will be an adaptive parallel group design, 12-week study with BID treatment with STP1 in ASD phenotype 1 patients. First, we will start with what we call a sentinel study. The purpose of this sentinel study is to basically eliminate one dose so that we can remain adequately powered with more promising doses in the 12-week treatment. One of the major challenges of this type of applications in clinical development is that when you're doing precision medicine, you're deploying an enormous effort to be able to screen very large populations of patients, and it funnels down to a very small number. But ultimately, a clinical trial is about reaching statistical significance to show, or sufficient statistical significance to show that the effect of your treatment. So the pro is that the signal is expected to be higher, and this study was powered on the basis of the results of our phase 1b, and we're talking about small n's compared to the classical phase 2 trial designs. We're basically talking about roughly 20 patients per arm, which allows us to reach a p-value of 0.01 in terms of statistical significance. Dosing for 12 weeks because our objective is to clearly get efficacy readouts correlating with EEG markers and very promising PK/PD modeling, so this can progress to the next step. So yeah, I'm done and happy to further take questions afterwards. Thank you.
Thank you very much, Lynn, for, again, a proof that we are ready to fly facts. So thank you very much. Maybe we're going to put chairs here for 10 minutes discussion before the lunch break. So if our speakers want to come in the front.
So yeah, I have immediate reactivities from the immunologist that I am. I am born immunologist. So the way you define inflammation or immunometabolic disorders is not completely in line with what I have in my own mind, you know, as an oncologist and tumor immunologist. So for us, we moved from the CRP and the IL-6 and the TNF. This for us is completely, let's say, aspecific. And we are more in the myeloid or the granulomonocytic precursors and the bone marrow signal. So NRF2 is a target of granulomonocytic emergency hematopoiesis. It is. I didn't mention the NRF2, but it is one of our targets. Well, yeah. So Miriam Merad in Mount Sinai and and their colleagues are showing that it is actually dictating emergency hematopoiesis in cancer. And so basically, we defined inflammation as an abnormal reactivity from the bone marrow precursors. And then we have two main signaling, the NF-kappa B on one hand, the type 1 interferon on the second hand. And then we have the IL-17, which is more a signal from the gut. And so the question comes, if you consider to stratify that way, would you think you would observe something, a different picture, a different heat map, a different non-hierarchical clustering methods to reclassify your inflammation? That's question number one. And question number two is that we were very surprised during the COVID period. The immunologists started to look at the antibody, the baseline antibody response against self-protein. So we have circulating anti-GM-CSF, anti-interferon alpha-2, anti-interferon omega, etc., etc. And we started to see that, for instance, people that have anti-interferon type 1 antibodies have less lupus and more severe COVID. So, you know, we know that type 1 interferon is actually very pro-anhedonia. And so this is also another angle looking at the autoreactivity against seminal regulators of cytokines and inflammation. And this is something also which is missing from your picture. So I want you to react on that. And the third question is GLP-1 inhibitors. We know that GLP-1 agonists are actually extremely good for weight loss and so on, but it is promoting anhedonia and, you know, so what is the picture on that? What can we learn from that? Yeah, everything is difficult. Everything is difficult.
I'll just touch on the first question. I think we don't have the granularity to look within the inflamed group of depressed patient, what if there are further subgroups, and all of the type 1 signal, NF-kappa B signal, and IL-17 signal are all elevated, so they're all kind of coming up in the studies that looked at either molecular profile or kind of plasma biomarkers. And the animal models tell us or propose that the depression and inflammation, at least in a subgroup, so some in the individual, is driven by monocyte activation starting in the bone marrow, assuming that it happens exactly as in animal model of stress or depression. So we have some understanding, but I don't think we have enough to even been able to dissect. I mean, obviously the additional question is, if we dissect so much, do we then have the tool to target one group versus another? Because if you end up giving them celecoxib anyway or minocycline, we might as well give it to everybody who has some kind of inflammation until, you know, in 10 years time we have cheap, available, easily tolerated anti-inflammatory that target only one mechanism. So that's kind of my comment. Anybody wants to go for that?
I would like to comment on NRF2. So it's only answering a small part of your question, but I'll start with that. So I didn't present the phenotype 2 here, but in our observational biosampling studies, we did observe in our phenotype 1 patients that they have upregulated expression of NRF2 target genes. And we actually observed the opposite in another subgroup of patients with the same DSM-5 diagnosis of ASD, and that was our rationale for pursuing both target groups in parallel, because what we usually, so that goes to a regulatory standpoint, the FDA asks you to show the specificity of the effect of your drug in your enriched population of patients with ASD versus non-enriched population. And we thought that one of the ways that we could approach this is saying, we'll do a crossover, and do you really want us to do this? Because we have biological data showing opposite gene expression profiles with regards to NRF2 target genes in these two autism populations. So then that's it's their decision to be made. And we're on our 1,200 patients biosampling funneling study. We're validating these NRF2 target genes expression profiles, and we're really finding two distinct groups. Two distinct subgroups. It doesn't mean that that encompasses the whole of the autism population, but I'm very interested to further discuss this with you because it has clear implications from a phenotyping clustering perspective and also from a mechanistic understanding perspective of what we're dealing with beyond the course psychiatric diagnosis. And I think we have a lot to, or we can leverage on what has been done in immunology and oncology in that regards.
Are there, Marion, it's 1 p.m. now?
We got 10 minutes left. We have 10 minutes.
10 minutes. Okay,
Now
so
we have 10 minutes.
Great. So maybe what we can do then is also because there are lots of people online, and we sometimes in this room forget about that, but it's really nice to see that people online are engaged as well, and they come up with quite some questions. So maybe just to start one question, I think we have actually addressed some of the questions already. Maybe a question for Carmine. If we were to use drugs to decrease inflammation, how many of the drugs that we use for that pass the BBB, the blood-brain barrier?
Okay, so we were discussing this today. I don't think we don't know, and we don't know in other direction because we don't know whether, for example, the just simple pharmacological data that we have from animals apply to humans during depression, because it is possible that we change the blood-brain barrier permeability associated with inflammation. There is perhaps increased access of some of these drugs to the brain that we don't know of. Animal studies suggested the minocycline, potentially celecoxib, and they mentioned, we're discussing this today, could enter the blood-brain barrier, but I think, you know, it's really not, we don't know whether more of them could enter. And I mean, obviously infliximab or antibodies that have been used in clinical trials with an effect are big molecules. So so it's quite, we just don't know whether you need an effect on the brain, whether it's okay just to have an effect on the periphery, and whether we're getting the effect on the brain. Yeah.
And a question for Charles. The question online is whether it might be possible to target it with transcranial focused ultrasound neuromodulation.
Yes, that's also a topic of investigation. But it's possible exactly the same way as is possible with TMS. It's even more focal than TMS, so it's possible to target a very specific brain region. But yeah, the question is definitely yes.
Good. Then maybe one last question for Lynn from the online audience, and then we will see whether there are more questions here. And that's about the EEG data. So there are some questions on how do you establish the baseline of EEG? How do you measure the EEG data? So I think there are some questions raised on that.
So the EEG data is compared with control baseline EEG data. There's been a lot of data generated in the context of Fragile X studies, which have guided the way to establish EEG standards in neurodevelopmental disorders, and so it's compared with healthy volunteer control databases, and it also compared with Fragile X data. So there are good baselines that are established with regards to what you expect to see in EEG in age-matched controls at baseline. And I have a question for you. You mentioned exercising in immuno-enriched subpopulations of patients with depression or diagnosed with depression. And I think that the panels that you show are very interesting, but the recommendation for exercise could eventually, correlating this with the panels, should, I believe, be cautioned with chronic fatigue syndrome that has the same type of panels, immune panels, or very similar immune panels, and that has also been shown to have metabolic and mitochondrial implications where exercise is contraindicated. So I think in publications where we mention this, it's clinically super relevant to mention that, because we don't want clinicians to be telling chronic fatigue patients who really have been associated with strong immune markers to go and take a run.
Well, I think this comes back to my remark that I made, that I think exercise intervention could be really a strategy that we need to implement in clinical care as well. But I think we really should be aware that that is not an intervention that will be, you know, the golden buzzer that will solve all the problems. It is also an intervention that does not work on everybody and that may not benefit everybody, like, you know, many of the other interventions. But I do think it is something that we should consider to complement the arsenal of treatments strategies that we currently have.
For sure.
I did see, yeah, Andy, and then a last question there. So I think after that, I think everybody wants to get lunch.
Yeah,
yes.
It's a very quick question because already Lynn maybe triggered this a little bit. It's about the interaction between you and pain clinics. You know, those people that are having patients with the pain, with the chronic fatigue syndrome, with fibromyalgia. You know how, because this is what is also about the interdisciplinary. How do you work with this? And I'm just asking, you know, from this angle of clinical kind of competences.
So your question is how do
you cooperate? You know, how these people are, you know, because patients are entering with this type of symptoms, you know, with the pain, you know, and depression. And so on.
Well, I
through
think
the pain clinics, not through the psychiatry.
Well, I think this really comes to a topic that I don't think we discussed this morning very much, but we touched on that, I think, yesterday, that I don't think that immunometabolic dysregulation, and I agree that we need to do a better job in further refining that, by the way, but I think that mechanism is not specific to certain mental conditions. I think, you know, Carmine and I very much come from a depression point of view because that's where a major topic of our research lines. But I do think, and we know this from the literature, that immunometabolic dysregulation is also present in part of people with bipolar disorder, for instance, and with schizophrenia. And I think it also really links very closely to certain conditions like you just mentioned that really are really clearly visible in the somatic field. So I really think this cross disorder approach is really relevant for us to consider. We need to extend our thinking much more in that direction. I think the problem is, if you, for instance, want to do a study in bipolar disorder or in schizophrenia patients, they have different assessment skills, right? If they measure symptom profiles, they are not measuring exactly the same as, for instance, we do in the field of depression and anxiety. And I think that is really limiting our potential opportunities to really look really across diagnostic boundaries and look at more general mechanisms. And I think this is what oncology was facing. I think 30 years ago, we just heard that they also were very much focused on their, you know, local cancer diagnosis, and then really realized that some of the underlying mechanisms were really general for cross-cutting several different types of tumors. I think we really need to go in that direction too. So really this cross-disorder thinking, I think, is really relevant. Yeah. You want to stop? And well, Andy, we give you the last question, a very short question and a short answer.
It's a very short question to Lynn. So important point that you made, and people should realize, if you're enriching, the FDA is going to make you prove that it works in the group that's enriched, and it does not work in the group that is not enriched. What is going to be your primary outcome variable when you move to phase 3?
So so as I mentioned, we've had multiple interactions with the FDA in the first pre-IND meeting, so pre-investigational new drug meeting. The FDA mentioned that they were in agreement with our first trial design, enriching the population, and that they agreed that it was a valid hypothesis to test, and that they wanted to see first the data in the enriched population versus placebo. Then they mentioned that down the line, they wanted to eventually see specificity data. And that's where we brought forward our proposal of having, of showing that we had two populations that had opposite biomarker profiles, and that there might be a safety and ethical issue in dosing, in considering that within the autism population, you had two different or opposite bioprofiles, and that our drug was targeting one. And so they took this into consideration, and they want to see the results of the phase 2 to determine if they maintain the requirement for specificity or not.
Do you have to do placebo in each one of those groups?
Oh, of course.
Yeah. And then what's the primary outcome variable in phase 3?
So the primary outcome can vary. Well, that's a big debate in autism. Okay, currently in autism, you have atypical neuroleptics, which are approved for irritability that can be associated with autism, and that's so unspecific, because if I give you or I take an atypical neuroleptic, yeah, I'm going to be pretty calm as well. So that is, but it's still a label that is approved for irritability that can be associated with autism, because you do observe these phenotypes at a higher rate than would be expected by chance in these populations. Then the core symptoms of autism is also a great question of debate, because we have within a DSM-5 diagnosis patients who have severe intellectual disability and others who function at a higher level. And therefore, it is difficult to find a label that will serve all these populations. So we think that the strategy, it is a valid strategy to go either for core symptoms of autism, so social communication deficits, and you can only capture this in very long studies. So at minimum 12-week studies to see statistically significant changes there. But you can also go for a strategy where you're saying, I'm targeting cognitive impairment that can be associated with autism, because it is known that cognitive level of cognition is a predictor of independence in life, which actually, and that's why we always say we're developing drugs that we're looking to provide patients with treatment options for those who are the most impaired by their symptoms. It's a long answer, but yes, you can go either for core symptoms. It requires very long studies within, and the population is very heterogeneous, or you can go for debilitating symptoms that will improve the long-term outcome measure.
Thanks. I think really this was a long, very interesting morning. We are now ready for first a picture that we will be taking, at least with the people physically in the room. For the people online, I hope you will have a good time having lunch. We will meet again at 2:15, so we will have an hour break now. First a picture outside, then everybody can go to the restroom and get lunch.